Okay, welcome everyone to our Buncke Clinic Virtual Visiting Professor Series. I am Bob Aksafa, and along with my partners, Greg Buncke, Rudy Buntic, Andrew Watt, and Walter Lin. I'd like to welcome you all. Tonight, we have the distinct pleasure of welcoming a true legend of hand surgery and microsurgery, Professor Joseph Upton from Harvard Medical School. Dr. Upton is a professor of plastic surgery, and his practice is primarily out of Boston Children's and Beth Israel Deaconess for the adult cases that he does. Obviously, Dr. Upton needs no introduction. He's an internationally renowned surgeon in many things, including congenital hand, and he's also famous for his collection of casts that you see here, where I'm not sure the exact number, but I'm sure they're in the thousands by now. He, as I mentioned, is an internationally renowned reconstructive surgeon and hand surgeon, specializing in many things, including congenital hand differences, as well as pediatric reconstruction from head to toe. He was formerly the president of the New England Society for Plastic and Reconstructive Surgery. He was also president of the New England Hand Society. He has authored over 250 peer-reviewed journal articles, over 60 book chapters, and 2 textbooks. And I'd be remiss to not mention that he also was the Harry J. Buncke Lecturer at the American Society for Reconstructive Microsurgery in 2013, where he delivered a phenomenal lecture that I remember very vividly, actually, many years later. So with that, Dr. Upton, thank you so much for being with us. It's really an honor and a pleasure to have you here with us. I am going to now make you the presenter so that you can share your screen with us here.
Screen share.
Perfect.
Okay, get back to the beginning. Wait a minute. Got to go back to the beginning here.
No worries.
Okay, how do I get rid of this thing in the upper right? Just
So the GoToMeeting window you can actually minimize. There's an arrow in the usually in the top left corner where you can minimize that, and then it won't hover over your slides like it does now.
okay, still in the right upper quadrant. It'll stay there.
Is it a large window that's getting in the way of your slides, or is it just a thin?
Maybe about 30%. I mean, I guess I can go without it. Okay. So first, I'm old enough to be still in the first wave of microsurgeons, and the first 10 to 20 years, we were just figuring out what flaps could go where and devising new operations. Most of that has been done now, and I think the challenge for everybody is one of refinement over what we've established. Okay, now I'm clicking to the next one. It doesn't. How do I get?
So usually either the right arrow can advance the slide, or clicking on the. Okay, looks like you got it.
So I'm going to show you a lot of cases, and they come from a book that 5 of us had put together. It's Bill Littler's idea. Hasn't been published yet because we're still waiting for permission for many of his drawings. Bill Littler was a surgical genius. He's the Michelangelo of hand surgery. And it's interesting as he got older how similar his appearance was to Leonardo, seen on the left-hand side. And this is one of Dr. Littler's many drawings. And this talk is basically about things points that he would bring up if he were alive. These are the kind of things that he would comment upon on the cases I'm going to show you. So the hand has a very unique architecture. There's a longitudinal arch, there's a transverse arch, and this shows the digital cascade, with the long ray being the longest and the 2 border rays being the shortest. There's a beauty in the form and grace of the hand, as well as the dynamic interplay, which is a whole different dimension which incorporates function. So here's a person whose cascade was restored with a second toe transfer. It's certainly much more satisfactory appearance while retaining and actually improving the function. Many of the things I'm going to show you have an aesthetic component, and that's one of the main points. In the past, we've talked mostly about function, but appearance is just as important in this interplay. Here's a guy, 27 years post-op. When he came in, he had 4 amputated parts. I put the central 2 digits back and, be honest, was just too tired to put the other 2 back. In those days, it was the late 70s, early 80s, and oftentimes we didn't have help with these operations. So the border digits were resurfaced with flaps of glaber skin. You can see the result 27 years later. This guy actually went into the service, became a career officer, and was discharged and never claimed any disability. Here's another man who came in 6 years earlier and had amputated his thumb and the tips of terminal portions of 3 digits. As a carpenter, he was very disabled. He couldn't manage to hold on to his tools and had a lot of trouble at his work. He came in, we solved the problem with the toe transfer in the long position because this primarily would improve the digital cascade. And as it turns out, it was the best possible position for him to grab onto his tools. Obviously, he's seen 15 years later, he was ecstatic with the result. And the appearance really didn't bother him initially, but he came to appreciate that with time. Here's a very unusual case. This is a teenage girl. Those of you who have teenage girls know how self-conscious they can be. She had lost her long finger at the middle phalangeal level. In our book, we classify this as zone 4. She did not want to have a toe transfer, so we solved the problem with a distraction lengthening, a technique that we've been using for a long time in very selected cases. And you can see her down below. She's maintained normal flexion at the MP and the PIP joints. Although she doesn't have a nail dorsally, the appearance is greatly improved. On the upper right, you see a symptomatic neuroma, which required rerouting. The longitudinal arch constitutes the resting position of the hand with the wrist dorsiflex, the MP's flex, PIP joints in gentle flexion. And this is the normal resting position of the hand and the position in which the hand is can function best. Now, disruption of the longitudinal arch with an intrinsic minus hand, such as you see here, is ugly, it's abnormal, it's dysfunctional. It's interesting that these patients with intrinsic minus hands clearly have altered function, but they're just as aware and of the aesthetic portion or the appearance and often hide these hands. We'll show you a possible solution later. But with these intrinsic hands, obviously the first thing is to, if there are motors available, to restore the functional longitudinal arch. Now, the resurfacing of the hand has always been a problem. I'm going to show you some preferred techniques. Clearly, there are many different ways to skin this cat. The hand is divided into functional units, as you can see here. And there have been many descriptions of the hand. We haven't published this yet, but we've added some additional ones, such as the interdigital web space. To those of you who practice pediatric plastic surgery, take care of congenital anomalies and burns, you know how important these areas of the hand are. So Here's a possible solution. This is the first temporoparietal flap that we described back in the late 70s. This guy was a carpenter. I saw him at the VA. He had put his hand in a glove for about 5 years, and this is a invasive squamous cell lesion. Interestingly, after we treated him, he did not develop any metastatic disease like many of these patients do. This is the temporoparietal flap covered with a non-meshed skin graft, and you can see this result a number of years later. He subsequently died about 20 years after this procedure. Another solution for the dorsal of the hand would be a fasciocutaneous flap, such as this TFL flap. Here's a guy with a massive crush avulsion. And the problem with these flaps is that they're the virtual bonus burger hand. This does not look as bulky as it really is. And the refinement aspect here is to first resurface it and then go back, in this case with liposuction. And in just one liposuction, we were able to thin this flap out. It, like the previous case, provides ideal coverage. It's thin, it's mobile. It allows gliding of the underlying tendons and movement of the underlying joints, and also a good milieu for doing the secondary extensor tendon grafts, and I think he also had some bone grafts. Now, elective dorsal incisions. What can go wrong? The points I'm going to bring up are things that both our orthopedic and plastic surgery residents repeatedly, year after year, come back and say, gee, that was really good. I didn't know anything about that. And I'm glad to know the rationale behind some of these incisions. So this case is one, it's a lymphatic malformation. Distally, these are very microcystic lesions. They have a rubbery consistency, and I think the goal I have is just to try to avoid making an incision in the very visible dorsal aspect of the hand. These lesions, the scars can be typically hypertrophic, as you can see down below, and this needed some intralesional injections over the years. But notice how the incisions are in the existing creases, the dorsal skin creases, and along the side of the digits, either in the high mid-axial line or the mid-lateral line of the digit. So here is this child 21 years later. You can see her arm on the left side shortly after she was born. She's had the arm, the forearm, the elbow debulked, the hand debulked, and we try to do as many individual areas at one time. If you're too aggressive and try to go circumferentially around a digit like this, you'll wind up with some skin losses. Another one in a youngster with an 11-year follow-up. It's better, rather than making the incision directly over the mass itself, to work around the border. So we went in the dorsal transverse incision that heals very well. All of you use it for ganglions, I'm sure. And then along the border of the thumb metacarpal, we were able to get all of the important structures. You can see how rubbery that lesion is. And obviously a very good result. These incisions are hardly visible. Now, palmar resurfacing is, palmar resurfacing is another major problem. There are no absolute perfect alternatives. This is case I did as a plastic surgery resident almost 50 years ago, and we're just putting these bonus burgers in the hand and debulking them. The palmar skin is well known to all of you. It's immobile or fibrous attachments to the underlying palmar fascia. The skin creases are all very predictable. And as you see on the upper right-hand side, we, as well as many other people, have divided it into many separate zones. Note the size and location of the first web space, which I think is very important. So palmar resurfacing always remains difficult. Like in a burn patient, you put a back on it and a skin graft, you know you're going to have a contracture. Here's a relatively small defect. It's a recurrent adenocarcinoma at the base of the ring finger, and this is about the third recurrence was sent. And here we've just created a local island flap from the ulnar side of the adjacent long finger, and the refinement here is just replacing like with like. And then in the donor side area, we're able to close about half of it, but we used a hypothenar graft for that area. And you can see 27 years later how well that incorporated in terms of color match. Although you can see the soft tissue deficiency, he virtually had no more recurrence after this aggressive resection and was very pleased with the result. Here's a local, this is a guy, a very wealthy guy, went down to see the Masters, Greg, a couple of years ago, and decided to go shooting the day before. And the cartridge blew up, and fortunately he didn't have any facial injuries, but sustained a lot of injuries to his left hand. You can see that the thenar muscles have been substantially mangled here, but some are still intact. So the refinement here is instead of just putting a skin graft on there and coming back and reconstructing the divot at a later date, or just leaving it. First, the debridement is done with removal of all the foreign bodies, but a local fascial flap was harvested from the forearm, put into the defect and covered with a hypothenar graft. And you can see the result on the right-hand side. This guy was out of the hospital in 3 or 4 days and back to work within a month. He was one of the orthopedic appliance salesmen. Notice that the forearm donor site has been closed with a subcuticular closure. Here's a very large palmar avulsion from a printing press, and this is one of the first ones that we did. This flap has been pushed beyond reasonable extension. Fortunately, it survived. I think we were lucky. We put a sheet graft on it. You can see the result at 1 year, and you see the result at 37 years when he came in with one of his grandchildren. Although there's hyperpigmentation and there's some hair formation from the skin graft, he finally got some electrolysis for that. Interestingly, we joined the auriculotemporal nerve to the cutaneous branch of the median nerve, and he does have protective sensation in all parts of that flap. Here's another one, a palmar resurfacing, difficult case. Patient first saw me at age 26. When I do Dupuytren's, I do a very deep dissection. I try to get all of the involved fascia out as possible. So he came back 18 years later. He's 44 years of age with a lot of pain in this contracted ring finger. So in this particular case, we took a small fat fascial flap with a long pedicle, hooked it up in Guillen's canal, put a hypothenar graft on it, and you can see the result about a year later. This guy happens to be a world-class kite surfer, and so far it's held up pretty well. That's his left hand that he's holding on to the kite with. Here, the refinement is to recapitulate normal as closely as possible. The first web space is a very special area. One of Dr. Littler's drawings is on the right side, depicting a tetrahedron, and this is somewhat of an asymmetrical area clinically in most patients, but is absolutely necessary if the thumb is going to be liberated and if the thumb is going to be able to move. Here's the ultimate contracture. We see a lot of this in burn patients, and simple but elegant solution is a distally based radial forearm flap. If the palmar circulation is interrupted, we get the flap from somewhere else and hook it up into the hand. One-stage reconstruction. Now, forearm incisions, Dr. Littler would go crazy with some of these incisions that we see. This is a young girl. She's about 9 years old, had a venous malformation that was misdiagnosed as a malignancy. So you can see she's had at least 3 major excisions here and has developed hypertrophic scars. So she has aggressive surgery for a benign disease and incisions that probably could have been strategically placed elsewhere. And so what happens with these palmar incisions? Here's a similar patient who's had a recurrence of venous malformation. You can see on the MR on the right, that's a T2 study, which shows it's just wrapped around everything on the palmar volar aspect. And the nerve lies directly beneath the scar, and where the blue points on the nerve are where the scar is directly adherent to the nerve, and where the nerve had developed segmental compressions, as you can see, the most prominent of which is distal. Here's the preferred incision, and this is what the nerve looks like after a microscopic neurolysis. So the point here is to avoid incisions whenever possible directly over key neurovascular structures. This is a drawing of Bill Littler's, and this is in a 1978 volume from the Educational Foundation of the American Society of Plastic Surgeries. It's one of the most important articles that's ever been written in hand surgery, and unfortunately it's been buried in a book, and it's very hard to get permission to publish this, republish it, which I think, and he goes over the rationale behind incisions everywhere in the upper limb. But here on the left-hand illustration, he shows that everything of importance lies between the flexor carpi radialis and the flexor carpi ulnaris. And that's an area where ideally you would like to avoid direct, I mean, you have to open it up directly, but you would want to avoid an open incision. The old tenet, one wound, one scar, certainly applies in these cases. Now, another observation I've had over the years is that years ago in the 80s and the 90s, the most popular flap was latissimus dorsi and then rectus. And we put muscle on everything and then skin grafted. On the left-hand side, you see a latissimus dorsi muscle. You see the skin island on the left, on the proximal portion. And this coverage, even though it gives coverage initially, doesn't really always stand the test of time, particularly if you have to do a lot of underlying reconstruction. So now what we're doing, or what we've all been doing, are these huge ALT fasciocutaneous flaps in situations like this, which I think is fine. But the refinement part is to go back and really debulk these and establish normal contour. Irregardless of who the patient is, they all appreciate the secondary revisions when they're done. Now the case on the left, on the right, I'm sorry, was she's a sea captain of a swordfish boat in North Atlantic, and she can swear with the best of the sailors. It's kind of a rough, tough lady, but she really wanted to have this contoured properly. And so we thinned out the ALT initially, and here she is 15 years later with no revisions. I'm surprised that she hasn't put a lot of tattoos on it, but we subsequently then started thinning these flaps out fairly aggressively, and Matt Iorio published that a number of years ago. Here's another forearm problem. This is a pediatric Volkmann, and this is a severe Volkmann's, but the interosseous artery is intact. That's why the hand's alive, and the median and all the nerves are intact. So in this particular girl, from the Shrine, we resurfaced the volar and dorsal aspect with a latissimus flap and put the muscle into the extensors. Then, as you see on the right-hand side, we put a gracilis muscle into the flexors. So we had some extrinsic flexion and extension at the for the distal portion for the flexion of the digit. And the intrinsics were working well enough, so she had MP flexion. The problem was when she became a teenager, she gained a lot of weight. So the refinement here is you just have to go in and keep on working, and we contoured it so there was much improved, but you can see even here she's gaining a little bit of weight, but she now has sensation. She has limited flexion extension, but more importantly, she does have use of that hand. Another case from the Shrine of forearm resurfacing. This boy has a lot to lose because he doesn't have a hand and forearm on the opposite side. Most of our residents don't get the chance to see a thoraco-abdominal flap such as this, but these are real winners. And I prefer to do this instead of multiple free flaps. They're pre-expanded, and we really expand them as much as we possibly can before burying the arm in the flap. And you can see it is possible to get around the forearm circumferentially with this technique. The closure of the incisions, this is what I learned from Dr. Littler. We never closed anything with more than a 6-0 mild chromic. He'd put a couple of subcuticular sutures in. He'd always say, well, the surgeons are recognized by the tracks they leave behind. But this is really all that's needed in a reliable patient with adequate immobilization post-operatively. Obviously, if you're going to let them move right away, you need some non-absorbables. Similarly, as I showed before, longitudinal forearm incisions actually look much better, they heal much better. It's important to try not to put the incision directly over the area of the structure which is being manipulated surgically. Now, going on to thumb reconstruction, in this book, we've divided it into 10 different parts. Obviously, that's 10 separate lectures, but a few take-home points I put together for you. First, the differences between the thumb. This is a normal appearing thumb on a Caucasian female hand fell. And the thumb is above and the digit is below. So we would like to recreate normal whenever possible. There's a funny story behind this. This is drawings by Bill Littler, and for 25 years, whenever he visited his brother in Providence, I'd go down and spend the day with him. So this is a summer day. We're sitting in his brother's front yard. The professor had his sketchbook and I had calipers and a pad, and we were measuring everybody who walked by. So by the time the afternoon was over, we'd measured about 20 males and 20 females, all adults, and this is the result. And it's amazingly accurate, and you can see all the little subtle things that the artist would see that the medical illustrators don't, you know, like that little fold on the great toe and the asymmetry and the axis orientation. So with toe to hand transfers, we try to recreate the thumb, and sometimes we become a little bit closer than others. So here's a patient who has great toe on one side, second toe on the other side. I mean, you pay your money and take your choice. So this patient, like most, liked the left side because there's more, with a second toe, because there was more motion, but preferred the right side for pinching activities, particularly tripod pinching, because of the flat surface of the pulp and the increased contact between the two. So many times these patients will tell you exactly what they need to have done when you're trying to decide. In the early 80s, it's interesting, Fu Chen Wei and I had the same idea independently, and that was to modify the great toe, to excise both bone and soft tissue. For me, it was kind of obvious because I take and still take care of a lot of thumb polydactyls. So we'd be making one good thumb out of two. And here we're just keeping the axial blood supply intact on one side. So you can see this is a methyl methacrylate simulation of the opposite uninjured thumb in this patient. And we measure things exactly right. And in the lower, 26 years later, you can see that the thumb, which actually looks as good as the other thumb, has a nice broad surface. Here, it's interesting when you compare it to the uninjured toe. Now, at this point in time, you can really fashion whatever you want to make a thumb. On the left-hand side, you see the great toe, which has not been altered. On the third panel down from the top, you can see the clinical appearance post-op. Next one, second toe, then the trim toe, then the wraparound, Wayne Morrison's operation, in which the soft tissue was wrapped around a bone graft. This became less popular because these bone grafts often resorb quite a bit. Individual nail complex can be taken, and on the right you can see a pulp transfer. This is an interesting concept. You take one toe to bulk up the other toe. This is the idea of Guy Fouché and Graham Lister a long time ago. Recently, the Chinese have really refined this operation quite a bit. I've done a few of them. The problem I had is I'd make it a little bit larger than this one, but that pulp tissue oftentimes is a little unstable. So you have to be careful not to disturb what fibers septi are there in the first place, but it definitely is an improvement. Here's a very unusual case. None of you have seen this, except maybe Harry Buncke was one who taught us about this and why not to do it after a while. Here's a gunshot or a 4th of July explosion, loss of the thumb at the MP joint. And some of the first toe transfer we did, we took the entire dorsalis pedis. And we learned subsequently that the skin graft is better tolerated on the hand than the foot. But you can see the follow-up in this young boy who he's now in the 42-year follow-up, something like that. I did it in the first year. But there's several things we learned, and Harry Buncke was the one who pointed this out. One is that the skin graft is better tolerated on the hand than the foot. that without the constant weight bearing and pressure, the pulp will atrophy on the pulp surface. Sensation is better in the hand, and the appearance, it still looks like a toe, but it doesn't look like the opposite toe. Here's a similar case, and the question is, well, what do you do when you, we had planned to do a modified toe transfer in this girl, and before we detached the toe, we turned the tourniquet down. There was very, very sluggish flow. So we decided just to leave it as is. So I think that's the best thing to do. And then we came back at a later date and finished our modified toe transfer at the strong urging of the patient. She was very, very conscious about the appearance. So here she is, 19 years and about 6 kids later. The donor site has not been problematic. You can see the appearance of the toe. She uses it in pinch. She has very little interphalangeal joint motion, but excellent MP motion. And you can see in the lateral contour that it's still a little bit bulkier. It's very hard to simulate that tapered appearance of the tip of the thumb pulp. Now, not all cases need to be refined. Here's a man who is 40 years post-op. I remember when he came in, mangled hand, he constructs and fixes the roller coaster in a local amusement park in New Hampshire. And he was devastated by this injury. We did a stage flap and then a toe transfer. Everything went well. I didn't see him for 39 years, and he came back, and the reason he came back, he had cancer, he was terminal, and he just wanted to thank me for doing this because it enabled him to keep his job and support his family. It was very, very important to him. Here's an unusual pediatric case. This is a cleft hand foot patient. On one foot, there are 2 great toes, as you can see in the upper panel A. So here we've taken the lateral of the lesser of the 2 great toes and performed a toe transfer. There were many open areas that need to be skin grafted, as you see on the left-hand side down in C. So the refinement here was we brought her back maybe a year, 2 years later, excised those hyperpigmented areas proximally, and exchanged her skin graft for a glabrous graft taken from the hypothenar region. Again, a refinement, I think it's very important to do these things because they make a tremendous difference to the patient. Here's an ultimate, what I call this the ultimate cosmetic operation. This is a closed patient with a tremendous overgrowth of the thumb and the index finger. So initially, we tried to debulk the thumb. That didn't work. And I know all of you will see one of these patients sometime in your careers. So we debulked, when we debulked the arm and the forearm, we also debulked the thenar region and did a free toe transfer. Subsequently, due to overgrowth and stiffness, we sacrificed the index finger, and you can see the mold down below. And this is a functioning post. It does have sensation, but not a lot of mobility, but it's a marked improvement from what she looked like at the time of birth. Now, in digital reconstruction, the pulp is a little bit different. The orange area here is the pulp, and the dark rust colored is an area I think that we should concentrate on more, and that's the fingertip. So here's a guy who comes in, and he's an Irishman. He likes to drink a little bit, and 17 years earlier, I had reattached this index finger, his long finger, which were amputated. And then he injured it again. He calls up in the middle of the night. He says, "Doc, I did it again." So instead of doing shortening and he wanted to use this finger. I didn't want to take too much length because it would be fairly non-functional. So this is a cross finger flap, and you can see the result below. At the time, he was 55, 60 years of age. Since having this reconstructed about 5 or 6 years ago, he hasn't been back, and he's been very functional. He works as a carpenter. So we maintained the length, we maintained his cascade, but more importantly, we were able to save some function. Here's one of the procedures that I think we're doing more. I think this is a much more physiologic approach. You can see the distally based island flap taken from the side of the finger, and the donor area is covered with a full thickness hypothenar graft. This is a one-stage procedure, and they do pretty well. You can see this man 2 months post-operatively, and he's gone on to do very well. Now, the same type of procedure, this is a proximally based island flap. It's just advanced to the tip as a V to Y, and very simple, elegant solution that puts Glaber's skin exactly where we want it. I remembered this girl very well. She had had a fingertip injury. You see the ring finger when she was 2 years old, and she then came in about age 6 because she's having some problem with the nail, and so I did a thenar flap. Of course, everybody thought I was absolutely nuts and crazy, you know, and they said these don't need anything done. But the point was that she had become very symptomatic and was complaining. Notice that the very tip of the finger, we don't have the bulk, the normal bulk of the pulp head, and this is true with just about every reconstruction that we do. Down below, you can see how she suddenly appeared as they scrubbed into a case. She is a pediatric surgeon. She was a pediatric surgical fellow here and says, "Remember me?" I had no idea, but then I got her old slides out, and sure enough, she has no pain or discomfort. She has normal sensation, normal range of motion. It's this hyponychial area, which I think is becoming much, much more important for our hand function now, particularly with the use of cell phones and screens. This is an area that needs to be reconstructed very carefully, not with scar, but with sensate glabrous skin. And I think that's a challenge that most of us have, taking care of these. Here's one where the transverse cascade has been reestablished with 3 toe transfers. This is one of Fu Chen's cases. But the reason I show it is to show on D, on the left-hand side, it's important to recontour these. If the patients don't like the appearance, elliptical excisions are all you really need. It's important not to undermine the pulp on either side when doing these excisions, but these can dramatically improve the appearance of the finger. It doesn't, with the midline incisions, these are not hypersensitive scars in most people. Now, here's some of you may be familiar with this case. It's one of mine, which is constriction ring syndrome. This patient had a quad toe transfer, which you see in the middle. And here we are, we've got 4 toes on the end of the hand. But important is the pulp revisions that we did on 3 of these 4 fingers. Now here's the 14-year follow-up on this kid, and we've gone to great lengths to make them look like normal fingers, and we've come close. It's not perfect, but the nice thing about the donor site here was that she didn't have any toes on the other foot, so the parents initially had no qualms about taking a toe, taking multiple toes for transfer. This patient's actually done very well. Another unusual case of a digital reconstruction is this kid with symbrachydactyly. This is pretty confusing, but in A, you see the original appearance. In the middle, what we did was we transposed the index into the long position, and we took the entire long metacarpal out. So we didn't have to do any stump fixation, we just moved it right over. Then on B, we put the metacarpal just in the soft tissue in the proximal phalangeal position, and you can see what happened to that. It almost completely resorbed. Then it started to grow a little bit, and by the time she was 11, it had grown some more. And then at the time when she was 20 years of age, we did a distraction lengthening. Now, this whole time, the thumb and the index finger are functioning just well enough, and the fifth finger is also a pincer with the thumb. So here you see her at 10 years of age, at 19 years of age, and when everything was complete at 22 years of age. I would emphasize this is a typical congenital case. These patients become your patients for life until either they die or you retire or die. And the soft tissue manipulation that you wind up doing is extremely important, particularly in the first web space. Now, when she was 19 years old, it kind of had a bizarre appearance. She kind of persisted, as did her parents, in wanting to have something done, and we were able to give her a good looking hand and a good functioning hand. Now, elective digital incisions, we've got 10 minutes to go here, almost done. In full flexion or extension, the digit encircles what Littler would call a polar axis, and the areas that come in contact with that rod form these diamond-shaped areas. And it's around these diamond-shaped areas that incisions can and should be designed. And this whole system was conceived of in the 40s and the 50s, where the primary operations done by hand surgeons were drainage of infections, and putting an incision perpendicular to a skin flexion crease was known to be disastrous in terms of creating flexion contractures. So you can really go around this periphery in many different ways. There's a lot of flexibility involved. And here's a particular case. It's a burn contracture. You can see how the releases were done. There's two diamond-shaped defects. A pin is used for fixation, and this is a typical digital release. This happened to be one of my board cases when I took my boards about 43 years ago. And when I look at it, I see I didn't make the diamonds large enough. I should have cut back a little bit more. But this is the ideal way to treat it. We save what skin is there and viable. So you can see her at 6 months, 1 year, and then by 9-10 years of age, she was beginning to get some flexion. It's interesting that because the nerves are intact, the sensation in the skin was intact, but it hyperpigmented and periodically would have fissuring if it wasn't well lubricated. But the point I like to make is that although this incision started in the high mid-axial line, they contract and they migrate palmar. And so it's a continual problem that has to be surveyed. Here's Cleland's ligament, which kind of anchors the skin on either side, as all of you know. It's a vital structure, a very important structure, particularly in identifying the neurovascular bundle. You're doing a replant, as soon as you find Cleland's, you're you're in good shape because you know that neurovascular bundles are going to be underneath. Grayson's ligaments are much smaller and are not as consistent, but are present normally. What is problematic with these incisions, and there are very few of our residents avoid this trap, is it's most vulnerable at the level of the middle phalanx and DIP joint, where the neurovascular bundle is almost directly subcutaneous in most patients. So this is where great care must be taken with these incisions. Here's just a typical case of the dotted areas are neurofibromas with an NF patient. You can actually, down below on that, what I'm showing is a sensory branch of the digital nerve that's going right into the joint space. The last thing I wanted to address that's relatively new, but not really, is the whole concept of fat transfer. Of course, our colleagues doing aesthetic surgery are much more involved with this, but over the years, I mean, people my age have done dozens and dozens of these dermal fat grafts. This is a triphalangeal thumb reconstruction with no thenar muscles at all. You can see in B on the right-hand side how we inset it and put pledgets around the whole thing. Here it is about a year or 2 years later, and you can see that there's been a considerable amount of atrophy, which is to be expected in these flaps. So I personally think it's very reasonable to put some vascularized tissue in there. It's a fun operation. It's easy to do. Here we've taken a segment of fat and fascia. This is a guy who was injured in Bosnia, had multiple nerve injuries, but actually has good palmar abduction of his thumb from a tendon transfer. And this involved just harvesting some fat from the opposite side. I think it's important to revascularize the other side. I've been doing it for years, but I haven't studied them to see what the flow dynamics were 1 month, 1 year, 5 years later. I've just been doing that. And here you see the early result from this dermal fat graft, which will not diminish in size over the ensuing years. Here's another option. This is a multi-trauma patient who had already had 3 or 4 free flaps on his lower extremities, and one of my colleagues was also taking care, went ballistic because I said, this guy doesn't need a flap, he needs a skin graft. So I put a skin graft on him, MP joints for inflection, and B on the left-hand side, you can see that 3 of the extensors were adherent. So I had very little motion. But here with a good skin graft, you can go and do a tenolysis and just fat injections, start moving them immediately. And that's what was done, and you can see the result on the right. The 5th finger has a lag, but that's more related to a fracture than the extensor excursion. Now, here's an octogenarian. Obviously, she's had a facelift and a blepharoplasty, but the hands give it away. And simple fat injection into the interosseous areas and the dorsal aspect of the first web space is an easy solution. Patients certainly appreciate it. And this is the difference you can get just with one simple session. The other application that we've seen is atrophy from steroid injection for dequervains. And the interesting thing about this is the skin hypoplasia that she had initially improved after the fat injections, which probably stimulated a lot of neovascularization, but I don't know exactly why, but we've seen this more than a few times. So that's all. I'm less than an hour. I think the the point of the whole talk is the whole idea of refining and trying to recapitulate what nature did initially. This is a Apert type 2 hand, and obviously you don't get from the left-hand side to the right-hand side without doing a lot of secondary trimming and correction of deviation, rotation, lengthening of the thumb with distraction lengthening, as well as soft tissue work in the interdigital web spaces. So that's it.
Well, thank you so much, Dr. Upton. Incredible talk. And I think one of the many reasons why I think we really enjoy this talk here at the Buncke Clinic is because we also believe that the aesthetics of the hand are oftentimes overlooked, particularly in traumas. I think it's all about trying to improve the patient's function, and very few folks actually pay the close attention that you've shown in the aesthetics of the hand in addition to the function, because after all, the hands are always out there, and as you mentioned, they do give it away. So I just wanted to make a comment on that. And along the same lines, we also believe that the importance of secondary reconstruction in all types of hand surgery, be it trauma or be it congenital, is also oftentimes overlooked. And so we oftentimes see folks saying, oh, replantation or complex hand trauma shouldn't really be done because the function is bad, when they never go back to try to improve that function. So I really want to thank you and commend you for your work in showing that the importance of these secondary operations in trying to maximize not just function, but also form. I had a couple of questions, and then I was going to open it up to the audience. You had that one really interesting case where the patient had one great toe on one side and a second toe on the other side. And obviously it was a really good opportunity to be able to see side by side, not only from an aesthetic standpoint, but from a functional standpoint, the difference between those two. As a surgeon, having seen that, obviously we saw a lot more great toes that you showed. Do you have a preference as far as great toe versus second toe, let's say for an adult?
I try to listen to the patient, and if you sit there and listen long enough, they'll eventually tell you what might work better for them. You have to get a good sense of their concept of the appearance and how much they rely on the function. I know years ago, I was in China just after it had opened up after the revolution, making rounds, and they were doing toe transfers, and everybody had a left second toe transfer. I said, what are you doing this for? You do any of the others? No, everybody got second toe. And because that's the way their system was. We're able to individualize things. One of the beauties of the molds is you can show them the molds, you show them what it looks like. You can show them pictures, and then describe what you think the functional benefit will be. But it's interesting that most consultations start and end with a discussion of the donor site. Mm-hmm. And the donor site morbidity is not nearly as great as we thought it would be when we initially started doing these operations. Harry Buncke kept on telling us, don't worry about the donor site, you're going to be fine. And he was right.
Yeah. And have you found that given both options and the molds, that your patients in general tend to favor one over the other, or is it kind of pretty much evenly divided?
Well, if there's any controversy or if there's any doubt, I'll hook them up with patients who have one or the other. But in general, as I showed, that's a great patient to show because the patient had more motion with the second toe and used that for precision type, threading a needle, things that she did in the kitchen, and little fine precision activities, but used the broader great toe for the power pinching.
Yeah, and I just want to mention that we had Professor Fu-Chan Wei on a few weeks ago, and he spoke about toe transplantation, and his experience exactly mirrored yours as well, in that the second toe offered typically better range of motion, right. But poor aesthetics. The great toe had typically looked more like a thumb, obviously like a big thumb, but the range of motion was clearly less. Now, with regards to some of the cases that you showed where you're doing purely what somebody could call aesthetic hand surgery, let's say a little free flap to fill in the first web space defect from a wasting of the first dorsal androceus, or some of the other cases where you're just building up the fingertips more for an aesthetic standpoint, have you do you have difficulty with getting insurance authorization? Are these things that are typically covered?
No, I haven't, because I always I always couch it in functional, and there usually is a functional component to it. But when I'm speaking honestly to other hand surgeons, like that macrodactyly case,
Mm-hmm.
we have a functional sensate post that's immobile there from the great toe transfer, and the patient does use it. The hand looks more like a hand, but 90% of the function is with the three unaffected fingers. So it emphasizes that both are important. It's a hand and glove relationship. You don't have one without the other.
Right. Makes sense. Dr. Greg Buncke, I know you're online. Was going to call on you for a question or comment. Are you there?
Yeah. Hey, Joe, thank you so much. It was a great talk. Unbelievable cases. Those the long-term follow-up was so special. It's really nice to see a 27-year follow-up, 40-year follow-up. That's great stuff. I'd love to hear more about Kauai and your 11 weeks of shelter in place there. But before that, I wanted to ask you, I'm intrigued by your ideas of putting fat transfer under skin graft after tenolysis. Is that what I heard correctly? Is that what you did in that particular case?
Yes.
So how did that work? So you had put a skin graft, it was stuck to the skin graft, and then you undermined all around the skin graft and got the tendon free and then injected?
No, there was there was maybe a few millimeters of gliding of the tendon, but
Okay.
small longitudinal incision. The tenolysis knives are straight. Just go on either side of the tendon and not do a massive dissection, but get it so that you can passively flex completely. In that case, we did a capsulotomy of the three joints at the same time, and then we just injected fat.
I see. So you're injecting fat through the same small incision that you did the tenolysis through. Is that the idea?
Yes.
Cool.
And the patient started moving immediately.
Yeah. Gonna try that. Thank you.
Roger Curry was one of my fellows. He says fat is good everywhere.
Right. He sure does.
He's injecting it everywhere. And I actually followed a couple of his Dupuytren's patients up here for him.
Yeah.
And even though they did have fat palms, the Dupuytren's has not recurred, although my follow-up isn't greater than 5 years on some of these patients, but I was impressed by that.
Well, he was injecting Dupuytren's after using Xiaflex too into the space in the Xiaflex injection spot. Have you tried that?
He injects fat every place, every time, anywhere, you name it.
I know.
So it's not a very controlled experiment, but I think there's some biologic validity or rationale there.
I agree.
I mean,
Thanks.
we haven't done a lot of cases, but it's interesting, and so far it's worked.
I want to just kind of comment that we do have both Amir and Sammy on the call or the webinar as well. So I wanted to welcome both of you. And Joe, in case you don't have access to the comment section, I actually wanted to read a comment that Dr. Taginia just posted. A great talk by a great master and a great mentor. I've had the absolute pleasure to have done an extended, well over a decade Upton fellowship. Every step and move has a distinct purpose. We don't see what goes on in the background. Attempting to do, quote, never before done cases takes a lot of courage. Thanks so much for this talk and for the years of amazing work and teaching. So I wanted to make sure that those thoughts were conveyed to you.
Oh, thank you. Well, Mears had the longest fellowship at all. It's going on about 15 years now.
Well, I know he's definitely enjoyed it from our multiple conversations.
It's been great. It's been great.
Excellent. Dr. Upton, thank you so much again for being with us. It's been a really an honor and a privilege to have you, and thank you for sharing your fantastic experience with refinements and microsurgical reconstruction of the hand. I hope to hopefully be able to see you in person soon, hopefully.
Me too. Yeah.
Great. Thank you so much. Have a great night.
Okay. Bye-bye.
Okay, bye.
Thanks, Joe.